The shoulder is a highly mobile joint. It allows extension, flexion, abduction, adduction, medial rotation, lateral rotation, and circumduction.
The anterior-inferior glenohumeral ligament is the most important stabilizer in 90-degree abduction and external rotation, as they prevent anterior translation of the humeral head. The labrum is also an important structure that surrounds the glenoid, adding depth to the glenoid socket.
The stability of the glenohumeral joint depends on static and dynamic stabilizers. Static stabilizers of the shoulder joint include the ligaments itself and the capsule. For example, the anterior-inferior glenohumeral ligament stabilizes joint during overhead movements. Meanwhile, the dynamic stabilizers actively contract the muscles to coordinate movement. For example, the deltoid muscle abducts and elevates the joint.
However, due to the shoulder being so mobile, it is also inherently unstable. Therefore, it is a common site of injury. And one of those injuries is the Bankart lesion. So the Bankart lesion is a detachment of the anterior portion of the inferior glenohumeral ligament complex and glenoid labrum off the anterior rim of the glenoid. This occurs in the 3 to 6 o'clock region. So in the Bankart lesion, the glenoid labrum is also removed, and this decreases the glenoid socket depth from approximately 5 mm to 2.4 mm. There are many variants of the Bankart lesion, and while the Bankart lesion can just be a soft tissue injury, there is also the osseous Bankart lesion, which involves a fracture of the anterior glenoid.
Bankart lesions usually occur due to an anterior shoulder dislocation when an applied force impacts on an arm in abduction, extension, and external rotation, tearing the anterior-inferior labrum in the process. Anterior shoulder dislocations are caused by sports like football, basketball, and lawn tennis, but most are caused by major trauma, trips and falls, and sudden and awkward shoulder movements. The patient is usually in some discomfort with the arm in abduction, supported by the other arm with the humeral head palpable anterior to the glenoid. Symptoms of Bankart lesions include shoulder pain, bruising or swelling, while chronic instability, recurrent dislocations, and limited range of movement are long-term symptoms. Plain X-ray is usually the first line of imaging for shoulder injuries. For initial assessment, AP neutral position, the guard view, and the scapular lateral view are appropriate to evaluate the glenohumeral joint for dislocation and possible fractures. For cases of recurrent shoulder dislocations, a West Point shoulder view should be done in addition to the standard shoulder protocol. The West Point view is a modification of the axillary view that improves detection of a Bankart lesion.
The ability of MRI to perform multiplanar imaging as well as its excellent soft tissue contrast makes it the ideal modality for imaging labral pathology such as Bankart lesions. The lack of ionizing radiation is a bonus, and it is often used to determine the severity of the injuries and to aid in treatment planning. A shoulder MRI is performed with the patient's supine and affected arm at their side slightly externally rotated. A shoulder coil is placed around the patient's shoulder to maximize signal-to-noise ratio. Routines vary from place to place, but a typical one may consist of proton density or PD and T2 weighted coronals, T1 and T2 weighted sagittals, and a PD axial with fat suppression on all sequences. Conventional MRI is often performed in patients with acute symptoms after the initial injury, as the fusion will often work as intrinsic image contrast. However, with chronic symptoms, MR arthrography or MRA is recommended. An MRA is an MRI scan where gadolinium-based contrast is injected into a joint prior to MRI imaging under fluoroscopic or ultrasound guidance. This will distend the joint, outlining the intra-articular structures. Contrast moves into the labral substance in the case of unstable tears and between the labrum and glenoid when there is labral detachment. MRA has high sensitivity and specificity, therefore it is the best modality when looking at Bankart lesions. As radiographers, it is our job to ensure that the pictures we take are relevant and demonstrate the pathology. So let's take a look at some useful views. Articular cartilage and labrum is best seen on axial and coronal planes appearing uniformly hyperintense in all MRI sequences. On T2 weighted images, edema from trauma can be easily seen as a hyperintense signal. On a patient with a Bankart lesion, MR images would demonstrate a disrupted medial scapular periosteum and irregular fluid seen as high linear intensities extending into the labral substance. Other signs include an abnormally small or absent anterior labrum and a double axillary pouch sign. Additional imaging of the shoulder in abducted external rotation view can further increase the sensitivity sensitivity and specificity of MRAs, as it places stress on the inferior glenohumeral ligament and anterior-inferior capsule, increasing visualization of anterior-inferior shoulder lesions. However, it can be a difficult position for the patient to maintain. Recently, studies have also looked into using 3D MRI as a tool for measuring glenoid bone loss, which is commonly found with osseous Bankart lesions. 3D MRI is a new technique that can be useful in this regard, providing 3D reconstructions comparable to 3D CT.
If MRI is contraindicated, CT is a suitable alternative for evaluating Bankart lesions.
CT is more accessible with less contraindications than MRI, but it also exposes the patient to radiation and has lower soft tissue sensitivity. Nonetheless, it provides multiplanar imaging with excellent fine bony detail to diagnose osseous Bankart lesions. 3D volume-rendered reconstructions of the glenohumeral joint are particularly useful as the humeral head can be removed to visualize the glenoid rim directly. This facilitates measurement of the location and degree of glenoid bone loss for pre-surgical planning. In addition, CT arthrography can improve soft tissue evaluation for non-osseous Bankart lesions. Although similar to MRA, iodinated contrast may obscure associated bony injuries.
Bankart lesions may be treated conservatively at first using immobilization or physical therapy. Arthroscopic repair is a common surgical method for managing instability and is preferred when Bankart lesions have been sustained with little to no glenoid bone loss and the patient is at a low risk of recurrent instability.
During arthroscopic surgery, a small number of incisions are made in the shoulder. An arthroscope is inserted into the joint, allowing the surgeon to view the shoulder anatomy without having to disrupt the musculature of the shoulder. With this guidance, the surgeon is then able to lift and mobilize the torn portion of the labrum. Several holes are drilled into the glenoid and an anchor is tapped into each hole. Using sutures, the labrum is then tied to these anchors, thus reattaching the labrum to the glenoid. At the end, all of the incisions are closed and sterile dressing is applied to the area. The patient then undergoes 7 to 9 months of rehabilitation. An alternative method of surgical stabilization is open surgery. As it is a more invasive procedure that requires the disruption of the subscapularis, it is now less common than arthroscopic repair. However, it is still preferred when there are associated injuries.